we're going to be looking at Chapter 7, the physiologic adaptations to pregnancy. So we know that during pregnancy there will be some changes in the body system, including the reproductive system. Those changes can be to the uterus, and we see that in physical growth and adaptation of that uterus. There's a particular pattern of growth as the fetus continues to develop and the uterus cavity continues to get larger. It's going to follow a specific pattern that kind of mimics the gestational weeks. Contractility, so the uterus is going to be able to contract and then soften and then contract in order to be able to deliver this baby. Uterine blood flow also will be significantly changed during the evolution of pregnancy. Before pregnancy, capacity of a uterus is about 10 mLs in volume and on average about 1.8 to 2.5 ounces. At 36 weeks, so late preterm, the uterus is about 1.8 to 2.6 pounds, and it can hold a capacity of about 5,000 mLs in volume. Growth is due to hyperplasia and hypertrophy as well. During early pregnancy, the uterine wall thickens, and in late pregnancy, we can see that the uterine wall actually thins, and you can palpate fetal parts through just palpation or also through Leopold's movements. Slide 4 is that visualization of that patterned growth that we had discussed. We can see typically right under those numbers that are midline. That would be the fundal height, so what the healthcare provider would be measuring in the office, typically during appointments, would be that fundal height in relation to the top of the uterus and the pubic symphysis as the markers for the measurement of that. During pregnancy, we also see changes in body systems, such as the cervix. We can see something called Chadwick's sign. Chadwick's sign is the kind of bluish discoloration of the cervix or the vaginal mucosa present during pregnancy. Goodell's sign is an indication of pregnancy. It's pretty much a significant softening of the vaginal portion of the cervix due to increased vascularization during pregnancy. That vascularization is typically a result of hypertrophy and engorgement of the vessels below the uterus. We could also see a development of the mucus plug itself, which is kind of like, for lack of better words, kind of like a cork in the center of the cervix, kind of sealing that environment there. Our next photo here in slide 6, we can see a visualization of a non-pregnant vagina and cervix, as well as a pregnant one. And if you look at the center of the pregnant portion of this diagram here, that centerpiece would be that mucus plug, that kind of like yellowish color there. Continuing on with changes in the body system include changes in the vagina and the vulva. During pregnancy, there's an increase in vascularity. So that vascularity is really going to affect areas of high circulation, such as the vagina and the vulva. Vaginal mucosa thickens during this time. Vaginal rugae can become more prominent due to vascularity as well as an increase in production of lactic acid. Ovaries are also affected during pregnancy. Progesterone must be present in adequate amounts, one of the hormones that drives pregnancy itself. The corpus luteum of the ovary secretes the progesterone, and ovulation ceases during pregnancy and focuses on the developing fetus in utero. There is also significant breast changes during pregnancy. Estrogen stimulates the growth of the mammary ductal tissue, so an increase in breast tissue can be seen during pregnancy. Progesterone promotes the growth of lobes, lobules, and the alveoli, which will be prepared in order to allow for lactation. Colostrum is secreted. Colostrum is the initial kind of golden in color milk is secreted by mothers who will be lactating and can be secreted as well as towards the end of pregnancy. And we can see a nice visualization, slide 10 there, of the non-pregnant, pregnant, and lactating mother. We can see how those milk ducts really kind of fill up with the nutrients needed to feed growing babies. Changes in body system also include the cardiovascular system. The muscles of the heart, or the myocardium, if you will, are going to enlarge about 10 to 15% during the first trimester. The blood volume in general is going to be increased. And when we're increasing our myocardium and we're increasing our blood volume itself, we're going to also have alterations to heart sound. So during pregnancy, some women can develop benign murmurs. It's a very common occurrence. Blood volume starts to increase by week 6 of gestation and can increase about 10 to 15% of volume during an entire gestation. Plasma volume increases as well from 6 to 8 weeks until about 32 weeks of gestation. We see growth as well in the red blood cell volume. Volume increases in the red blood cells about 20 to 30%, and this shift of an increasing volume in the plasma, increasing red blood cells, can create a physiologic anemia, believe it or not. And that is going to come into effect later on during pregnancy. And oftentimes women are asked to take iron supplements or a prenatal vitamin with iron itself in order to compensate for that physiologic anemia that can occur in pregnancy. Changes in body systems, again, continuing on cardiovascular system. Cardiovascular output increases with all that increased volume from the plasma and the red blood cells. We're going to need to increase our output as well, 30 to 50%. Systemic vascular resistance decreases during pregnancy, and this can be due to an influence of hormones really kind of relaxing those vessels. Blood pressure is affected. So if our systemic vascular resistance is going to decrease, it's going to decrease likely our blood pressure, especially affected due to position changes because of the increasing weight of the uterus, the increasing weight of the developing fetus. It can create some compression on our major vessels, including the descending aorta, and inferior vena cava, which can cause kind of like a vagal response in moms. Be very cognizant of a pregnant patient's position. And we can see that visualization of the compression in the descending aorta and the inferior vena cava in these photos here on slide 14. Blood flow, continuing on with the cardiovascular changes in pregnancy. Blood flow is altered. It's altered due to a growing uterus, right? We need to accommodate the uteroplacental unit. We need to accommodate for that fetal circulation to the placenta. So blood flow does become highly impacted during gestation. Renal plasma flow increases to about 30%. Skin requires increased circulation as it expands. Blood flow to the breast increases. Expanding the uterus particularly obstructs blood flow from the veins into the legs. So this can cause some strain on the lower legs of a woman during pregnancy, sometimes often causing vascular changes. It can cause some numbness, some tingling, depending if there is nerve compression there, and so on and so forth. Blood components are also affected during pregnancy, and there's increased iron absorption and increased clotting factors, again, influences from the RBCs and the plasma changes seen during pregnancy. Respiratory system also affected during pregnancy. There's an increased oxygen consumption. Kind of makes sense as the body continues to grow and develop, and you have a major organ that is requiring increased amounts of red blood cells. There's going to be a higher demand on oxygen. Hormonal factors can influence the respiratory system as well, including progesterone and estrogen. Physical effects on the enlarging uterus can cause some compression, temporary, though be it uncomfortable, temporary compression to the diaphragm as well as the other organs, including the lungs. Relaxation of ligaments around the ribs can cause some undue chest pain for women during pregnancy. And this relaxation of the ligaments is influenced by a hormone called relaxin. Relaxin really kind of helps promote stretchiness in the cartilage of these ligaments, which include the ribs, which include the pelvis. Ideally in the pelvis, it allows that baby to kind of accommodate a better fit into the pelvis, and in the respiratory system can cause some influences, some shortness of breath and some chest pressure related to growing fetus and compression on the diaphragm. There are also some GI effects of pregnancy, including appetite. We understand the compression in the diaphragm during the end of gestation. We can also see that influence of compression to the stomach as well, and other GI structures there. So an appetite might fluctuate. For a pregnant woman, she might have increased appetite earlier parts of her pregnancy, maybe the second trimester or so. She might have decreased appetite in the first trimester due to symptoms of nausea or vomiting. And in the third trimester, we might see that kind of wax and wane of appetite influences due to the compression of the stomach. Mouth, believe it or not, is also affected during pregnancy. Women can retain more fluid, so their airway might be influenced. So that would be significant for a mom, especially in labor and delivery, if she has a difficult airway and she has swelling in her mouth or her throat, her esophagus, anything like that. Also affects during pregnancy as motility decreases, which could affect the gallbladder itself. It could affect the ducts if there's decreased mobility or motility there. So interesting and important factors to consider changes during pregnancy. Let's take a look at changes in body systems which affect the urinary system. So we know the bladder is affected during the development of pregnancy, and that comes in the terms of urinary frequency, which can be seen early in pregnancy as well as towards the end of pregnancy due to compression of the bladder from the growing fetus. Kidneys and ureters can also be affected, the size and shape of kidneys, as well as functional changes in the kidneys due to increased demands. Changes in body system also includes the integumentary system. Our skin, hyperpigmentation can be seen in the nipples, it can be seen in the vaginal area, and that is due to a change in hormones. Linea nigra, which is a little kind of line that can be a hormone influence as well, it goes across other's abdomen, also can be seen during pregnancy due to the changes in hormones there. Connective tissue can also be affected, thus causing some stretch marks or striatum, which can occur as the abdomen continues to expand during gestation. Hair and nails their growth can be affected as well. Changes in body systems, the musculoskeletal system continued. Calcium storage is affected during pregnancy as fetal demands for calcium increase. Makes sense there. Moms need to have an increase in calcium and its storage in order to help develop strong, healthy bones for these developing fetuses. Postural changes can occur in a mother as her center of gravity shifts with the developing or a growing, I should say, uterus and abdomen. Abdominal wall tissue can be compromised and can cause a diastasis recti, which is the separation of the abdominal wall. There can be uncomfortable and can make moms feel like their abdomen is not supporting their gestated uterus. Endocrine system. Pituitary gland is going to be a very big hotspot, if you will, for the hormones needed to support pregnancy, prolactin and oxytocin. Oxytocin being the hormone that drives both pregnancy and labor. The thyroid gland can be influenced during pregnancy due to a shift in hormones. We can see a rise in total T4 as well as thyroxine binding globulins. It's important that moms have their thyroid gland and their labs drawn and checked during pregnancy in order to assess for any hypothyroidism or hyperthyroidism, as we can understand an influence in thyroid hormones there during pregnancy. Parathyroid gland is also influenced during pregnancy as there's a calcium homeostasis. The pancreas, there can be fluctuations in insulin production there, or even insulin resistance. This can be caused by gestational diabetes. Again, very important to have patients have all their prenatal testing. As the adrenal glands can also be influenced during pregnancy, increasing or decreasing cortisol as well as aldosterone. Changes can be caused in the endocrine system by placental hormones, including the HCG hormone, estrogen, progesterone, HCS hormone, and that relaxin hormone that I had previously reviewed during this presentation. Changes in metabolism. We already discussed kind of the changes in appetite and those such symptoms during pregnancy, but there is also an influence in metabolism. And I had mentioned before that motility decreases during pregnancy in our GI system. We can see increased weight gain, and that kind of makes sense as the uterus is getting bigger. It's accommodating a larger fetus, it's accommodating more amniotic fluid, a larger placenta. We see that reflection in the weight gain there too, but also influenced by changes in metabolism. Moms have that water retention that I had mentioned before. They have increased edema. That can cause compression of some of the ulnar and the radial nerves, which can cause a carpal tunnel syndrome during pregnancy, and changes to the carbohydrate metabolism for moms as well, using that as kind of like a quick energy store there. Sensory organs can be influenced during pregnancy. Moms can have a decrease in their visual acuity. Again, one of the many reasons why it's important to keep that open, honest communication between patients in the prenatal period as well as healthcare providers to support them if they're experiencing any changes in these sensory organs, such as eyes, ears, immune system as well. Autoimmune conditions can be exacerbated by the changes in hormones and fluctuations in pregnancy, and some moms can even kind of develop an infection resistance. The next couple of slides, we're going to talk about confirmation of pregnancy, presumptive indicators, probable indicators, as well as positive indicators. So presumptive indicators are things that would make us think that a patient is pregnant. That includes amenorrhea, nausea and vomiting, fatigue, urinary frequency, changes to the skin that we had previously discussed in this presentation, changes to breast tissue, vaginal and cervical color changes, and we knew those as Goodell's sign as an example, as well as fetal movement, which can be seen later in pregnancy. Probable indicators of pregnancy include abdominal enlargement with a gravid uterus, cervical softening, changes in uterine consistency. We talked about how the muscle tissue increases during pregnancy and its thickness, as well as kind of thinning out later in pregnancy, where patients themselves, as well as healthcare providers, are able to palpate fetal parts. Braxton Hicks contractions are kind of, if you will, the dress rehearsal for labor. It's the uterus contracting itself. So it contracts, which a mom could feel as tightening, and it kind of relaxes as well afterwards. Pregnancy tests will be positive as a probable indicator of pregnancy itself. And we can see on slide 30 of this presentation is just a visualization of allotment, where the cervix itself changes in consistency of how it feels from a soft to a more firm consistency. Positive indicators of pregnancy include auscultation of fetal heart tones or fetal heart sounds, fetal movements felt by the examiner, as well as a visualization of the fetus, typically seen on ultrasound. Next couple of slides, we're going to talk about the role of the RN in the antepartum part, as well as assessment and care for antepartum patients. Antepartum care is to ensure that pregnancy ends in a birth of a healthy infant without impairing the health of the mother. So again, our goal is going to be a healthy mom and a healthy baby at the end of this pregnancy. Preconception and interconception care. Ideally, patients would be seen in the office before conception. Helps healthcare providers identify problems. It can provide a patient with education to help achieve or to foster a healthy pregnancy. It would be an opportunity to obtain history, vital signs, physical examinations, any screenings, medications, nutritions, and be able to adapt a plan of care that would fit that patient's needs in orders of making any changes or fostering good health. The initial prenatal visit, again, helping to establish that open and honest communication between you and the patient, establish trust and rapport with the family, verify a pregnancy, you can rule it out or rule it in, evaluate women's physical health, assess the growth and health of the fetus, establish baseline data, evaluate psychosocial needs, assess the need for counseling or teaching, and negotiate a plan of care. So it's kind of laying down the foundation for a relationship that's really going to develop during the next several months. During the initial prenatal visit, clinicians typically are taking an intake on obstetric history. They are finding a patient's G's and P's, if you will. G being how many times they have been gravid, how many pregnancies they've had, and para, how many births they've delivered, or how many children they've delivered. We know that those numbers can differentiate. For example, a patient could be a G5P1. Perhaps she's had 5 pregnancies, maybe a history of some spontaneous abortions or threatened abortions, and para would be how many live births she's had, or births in general, I should say. It's important to obtain any previous obstetric history, such as lengths of previous gestations, weight of newborns, what their labor experience was, any complications during pregnancy, any complications during delivery, or any additional special concerns. Also during this visit, we're going to be taking an in-depth health history. When is their last menstrual period? What's the estimated date of delivery? Any medical and surgical history that can influence or impact pregnancy. We understood from the previous part of this presentation how much pregnancy really plays a role in all the body systems. It's important to get a really concise medical picture of these patients. After an intake, a physical exam is performed, getting that baseline information again, vital signs, cardiovascular system, endocrine, reproductive system, so on and so forth. The subsequent care for a patient during the prenatal time is for an uncomplicated pregnancy. I should make sure that that is said, uncomplicated pregnancy. Obviously, with a more complex or complicated pregnancy, this model would have to change, but scheduled for uncomplicated pregnancy for healthcare provider visits include visits every 4 weeks from conception to 28 weeks, 29 to 36 weeks. Patients are seen typically on a bi-weekly basis, and 37 weeks to birth, they're seen on a weekly basis, and 37 weeks is the beginning of a term pregnancy, full term being 40 weeks. Subsequent assessments and subsequent healthcare provider meetings include vital signs, assessing weight, again, that fundal height, making sure that we're following through on the growth development of this baby. Leopold's maneuvers would be a healthcare provider placing their hands on a gravid abdomen and assessing the position, perhaps the size as well of this fetus, assessing the fetal heart rate, fetal activity. We can see fundal height measurement in slide 40. Other assessments include any signs or symptoms of labor, educating our patients, ultrasound screenings, glucose screenings. We talked about that insulin resistance can occur during pregnancy. So there we can see that glucose screening. Isoimmunization is really going to be important, and again, play an important role as we can assess what immunizations a patient might need. Would this fetus be at risk for any type of illnesses as well due to any type of isoimmunization? Pelvic exams, again, to give us a baseline information on patients. Multifetal pregnancies are a little bit different. We are now taking care of likely 3 or more patients, depending on how many fetuses have implanted. It's important to assess maternal physiological changes, as we know they might be greater with multiple feti pregnancies. There's an increased workload for the heart, increased respiratory difficulty, and really kind of pull on the information that I had discussed in this previous presentation, and how each one of these body system changes with a pregnancy of one fetus, and really kind of put that into perspective of how that might be influenced with multi-fetus pregnancy. With multi-fetus pregnancies, it's important to have an early diagnosis if possible. These patients might need special antepartum courses. They might require more frequent visits and more frequent ultrasounds, and they might be at higher risk to have things such as diabetes, preeclampsia, hypertension in pregnancy. So it's really important that there is a significant amount of counseling done in these meetings, as well as discussing signs and symptoms of preterm labor. With multifetal pregnancies, moms are typically at higher risk for preterm labor than a singleton pregnancy. Common discomforts in pregnancy are often seen as nausea and vomiting, heartburn, and we can see that due to a decrease in GI motility, backache. Remember, moms are changing their center of gravity and perhaps using more of those accessory muscles in our back to support a gravid abdomen. Round ligament pain is a compression of the nerves we can see in the pelvis with a growing and gravid uterus. Varicosity is that thickening of the vascularity, typically seen in the lower extremities. Constipation, hemorrhoids, leg cramps, that increase in lactic acid. Antepartum assessment and care, we reviewed the preconception visit. We talked a little bit about that initial prenatal visit. Subsequent assessments, multifetal pregnancies, common discomforts in pregnancies, and just for a quick moment, we'll talk about cultural considerations. Culture does play a very large role and influence in pregnancy and in healthcare in general. So culture often determines the health beliefs, values, and expectations of the family. And as future nurses, it's important that we take some time to really consider how a patient's culture might influence their pregnancy, their experience, and their value systems. Family responses to physical changes of pregnancy. Oftentimes, moms will be accompanied by a family member or a partner during their visit, so it's a nice way to kind of bounce back and include them in the assessment. How are they affecting the gravid patient in general? What kind of nursing diagnoses are applicable to them? What are some expected outcomes? They can be really big helpers in terms of teaching lifestyle changes and helping to influence good behavior in gravid patients. Our last slide is another question. Hopefully, once this presentation is completed, as well as your readings for the week are completed, you'll be able to answer it with success. Which findings of the urine analysis of a pregnant woman is considered a variation of